Thank you. Oh, don't see you anymore. It's good. So, dear esteemed colleagues, ladies and gentlemen, good morning. I'm honored about the measure that you invited me again to talk to you. And for those who heard my speech already in Chicago, I'm very sorry. I would have loved to tell you something new, but unfortunately, nothing had happened. All I had to change in my speech after 3 years was to add 3 more years to my numbers. And I hope that at the end of my speech you will be convinced more than ever that these are 3 more years lost in endodontics. If I would have told you 25 years ago what I'm going to tell you right now, you may have booed or even left this lecture room under protest, what happened very often to me, because 25 years ago that was all kind of hypothetic. Today it's not more so easy because, as you will see, today everything is scientific proved facts. You will see a lot of X-rays of healed cases of apical osteitis because that's the only thing that makes sense when you talk about endodontics. The chronic bone infection is the point. But if you might think that these are Sunday cases that I show you, I must disappoint you because these are our everyday cases. And in our clinic, the way we treat, everybody is very astonished if an apical osteitis, even a big one, does not heal and does not. So let's start to take a look at the emperor's new clothes, and let's start in 2002, because in 2002, David Fichter was the first to point out that the success rates in endodontics had not changed since the middle of the last century. And Kojima et al. Were the ones who provided the statistical data 2 years later in a big meta-analysis which showed that David Fichter has been completely right. And latest, after Nung et al. Had re-examined these data and had come to the same results in 2007 and 2008, no one who was serious about medicine being a science could doubt any longer that David Fichter had been completely right. The success rates in endodontics have not changed since 70 years, and let me add this, they are as bad as ever. In any way, they are much worse than one would expect, treating a simple bacterial disease taking place in an anatomical surrounding that has been described for more than 100 years. Here are the published facts. Acute radiologically inconspicuous pulpitis, vital teeth. Almost 10% of the treated teeth develop chronic bone infection within only a few years. Non-vital radiologically inconspicuous teeth, about 20% of the treated teeth develop radiographic signs of apical osteitis within a few years. Non-vital teeth with radiographic signs of apical osteitis, roughly 30% of the teeth do not heal from chronic bone infection. The radiolucency persists or increases. And retreatment of teeth with radiographic signs of apical osteitis, almost 40% of the teeth do not heal from the chronic bone infection. The radiolucency persists or increases. Retreatment of already resected teeth with exacerbation, no reliable data. We fly to the moon and gradually get even the HIV infection under control, but we still cannot predictably heal a simple bacterial disease. That's as astonishing as disgraceful. By the way, in endodontic studies, we only examine teeth that have already reached the stage of definite root filling. All the other teeth where endodontic treatment is not even tried because the author regarded them as hopeless, and all the teeth that on the way to definite root filling are root tip resected or extracted because the treatment did not work, they don't find their way into those statistics, and the number of those teeth is not at all small. So you see, we only study cases that are already treated successfully to a certain point. It's the same as if in implant studies, early losses would not be considered, and only implants were studied that have at least reached the stage of osseointegration. So you see that in reality, the numbers are even much worse than shown in this graphic. How can that be explained? When I started practicing more than 30 years ago, I saw a lot of insufficiently treated, executed root canal treatments in the X-ray of my patient, like those two examples. So I did not wonder that they developed chronic bone disease or that an existent radiolucency persisted or increased. Today, it's completely different. Today, I see as often technically very nicely executed root canal treatments like this upper molar, for example, but the number of pathological X-ray findings still remains the same or even is worsens. And this is not at all my personal impression, but scientifically proved fact. For example, a Swedish follow-up study published by Eckerbohm in 2007 showed that the frequency of root canal treated teeth had increased from 14% at the beginning of the study to 18% 20 years later in the same patient group. That's quite a nice improvement, but it's not nice at all that the frequency of teeth with apical osteitis had more than doubled in this time from 3.3 to 6.8%. Although the quality of the root fillings had considerably improved, there was no corresponding improvement of the apical status of the treated teeth. In the contrary, it got worse. I'm going to show you today, that the explanation for this fact, which I call the endodontic dilemma, is very simple. So to do so, let's look at the anatomy and especially into the interior of molars. What do we see? We see a cavity system of with three or four main channels, but many little side and connecting and blind channels, and we have an apical delta, and not even shown on these pictures, a gazillion of tubules. And look at the number. This is 100 years ago that everything is known about that. And all these cavity system, all the little channels and tubules contain organic tissue that will be colonized by bacteria, just depending on the aggressivity of the bacteria and the time the infection spreads. And what can we do about it? Mechanically, we can only clean the main channels. What else could we do? There are no means to clean all these little channels and the tubules. They are just too small. And what is the result of our mechanical efforts? Scientific studies show that only a maximum of 65% of the main channels can be cleaned mechanically from organic tissue. They are free, and only 60% are free of organic tissue after well-executed treatment using the last methods and spending a maximum of time. You see, We cannot even clean the main channels completely from organic tissue, but these main channels count only for 50% of the whole cavity system. So let's look at the figures and make a simple calculation. 65% of 50% is about 32.5%. What we see is that 2/3 of the cavity system still remained mechanically uncleaned after an endodontist has spent up to 3 hours on the cleaning of a molar. In other words, even if we would spend 24 hours on the mechanical cleaning of a molar, and if by any miracle we would achieve complete cleaning, at least of the main channels, then 50% of the cavity system will still remain mechanically unclean. I'm sorry, but these are the facts. The anatomy is incorruptible. So the first conclusion we come to is that the endodontic dilemma cannot be solved by mechanical means alone. And this is exactly what Otto Walkhoff pointed out 100 years ago when he described the results of his histological studies by saying the mechanic is the servant of the disinfectant and not vice versa. So the second conclusion we can draw is that if we cannot solve the endodontic dilemma mechanically, we must solve it chemically. There's no other way. We should, of course, not renounce a meticulous mechanical preparation because preparing the main channels gives way for our disinfectants to reach all the potentially infected tissues. That brings us back to the quality and validity of endodontic studies. What is done in 99% of the endodontic studies that deal with disinfection? We plug paper points into main channels, take them out, incubate them, and count and classify the bacteria. Then we bring in all kinds of tinctures. After a while, we plug new paper points in the main channels, take them out again, incubate them, and count the survivors and classify them, with the result that not even the main channels are completely free from bacteria. And what about the rest of the cavity system? If not even the main channels are clean, the rest, in 99% of the studies, the rest of the cavity system is not studied at all because this can only be done histologically. Does that make sense to you? I'm sorry, but I can't see any. So the third conclusion we come to is that we can forget about almost all endodontic studies on disinfection which are not histologically. Let's now take a look at the outcome of the treatment of the first and most simple stadium of endodontic infection, the acute pulpitis. As an example, let's look at the study published by Gezi in 2006 because he applied the actually taught and so-called gold standard protocol. Gezi treated 244 patients with acute pulpitis showing no sign at all of apical osteitis in their x-rays, and he divided them in two groups. One group got a single visit treatment, and the other group got an inter-appointment dressing with CaOH2 for 1 to 3 weeks. And the result was that equally distributed over both groups, nearly about 7% of the treated teeth developed a radiolucency within only 1 to 3 years. Gezi concluded correctly that an inter-appointment treatment with CaOH2 does not seem to affect the treatment success in treating acute pulpitis. There's nothing astonishing about this fact because only 1 year later, Southern et al. published a big meta-analysis in 2007, and they showed that CaOH2 has only very limited effectiveness in eliminating bacteria from human root canals. And even worse, the studies showed that that CaOH2 is not effective at all at some problematic bacteria like Enterococcus fecalis, which we often find in severe cases and especially retreatment cases. But there is another conclusion that is drawn from this and other studies that come to the same result. People say that acute pulpitis can be treated in a single visit treatment. Of course, you can do this, but you can only do it if you are happy with an outcome with an only 90% success rate. And I would be very unhappy because that would make my treatment unpredictably. So this conclusion is completely wrong. The only right conclusion that can be drawn from these studies is that it's not the drug interlining which is not helpful, but that it's the applied disinfectant, it's CaOH2, which is just not effective enough. The fact that even in the first and most simple stage of an infection, nearly every 10th tooth develops chronic bone infection shows undoubtedly that the applied treatment protocol is insufficient and that this disease is obviously not treated appropriately. So it's as simple as that. We must treat differently if we want to improve the outcome and to a level that is comparable to the treatment of other bacterial diseases. And comparable diseases, bacterial diseases are treated with a success rate very close to 100%. But we will, of course, never reach 100%. 100% in medicine does not exist. Shit happens. But treat failure in every 10th tooth in the first stage of endodontic infection is disgraceful and not acceptable at all. Otto Walkhoff knew all this already 100 years ago because he did not only look at X-rays and plugged paper points into main channels, he examined even those simple cases histologically. Doing this, he saw that an acute pulpitis can very well be the result of an exacerbation of an already existing partial gangrene. Otto Walkhoff described histologically confirmed cases which were already partially changed gangrenous, some of them even showing microabscesses, although they clinically appeared as flawless vital extirpations. Results, though, that he described as most astonishing because he had never expected such findings looking at the clinical pictures. These histological findings show that the clinical picture can easily mislead us because it allows no reliable conclusions as to the severity of the bacterial infection inside the cavity system. If examination is done histologically, as done by Nair in 2005 and Lin in 2008, the results show that the so-called gold standard protocol is survived by numerous bacteria. And where did these authors find these beasts? They found them in the main channels, but particularly in the side and blind and connector channels in the apical delta and, of course, in the tubules. In other words, they found them exactly where Otto Walkhoff had found them already 100 years ago. If we take a look at really severe cases, we see that with the time the infection spreads, not only the entire cavity system will be colonized by bacteria, that also the neighbor tissues are concerned, as there is a periapical space, the periapical bone, and the granuloma and the cyst. The fact that these areas are infected or will be infected prior to treatment of severe cases cannot be doubted, because there are numerous histological studies that prove this fact. And how do we treat the areas outside the cavity system? Mechanically? Not at all. In the case of post-treatment disease, only by surgical root tip resection or extraction. Post-treatment disease is a very funny expression, by the way. Instead of admitting treatment failure, a new disease is invented. False treatment disease would match it much better. And do we at least treat the areas, the tissues outside the cavity system chemically? Not at all, because sodium hypochlorite is not allowed to get access to the areas outside the cavity system, because otherwise we would expose our patients to the risks of severe up to life-threatening side effects. And COH2, as we saw already, is proven to be not effective. Despite these facts, we are using it since 40 years, and we keep on using it, although we know everything better about his insufficiency since many years already. Why do we do such stupid things? We do them because our teachers tell us that we may not use cytotoxic drugs in endodontics. They tell us we should only use biocompatible disinfectants so not to harm our patients. Now, listen or read. A substance is considered to be biocompatible if it does not harm the living structures it contacts. What? We want to kill bacteria that make us sick and lead to organ loss if we don't kill them. How can we achieve this goal by using drugs that do not harm the living structures it contacts? That makes no sense at all. This is completely nonsense. This is the most biggest joke which is told in medicine, at least as long as bacteria are living structures. And there's no doubt that bacteria are living structures, because if they were not living, we would not have to kill them. Every disinfectant is cytotoxic. If it's not, it is none. Of course, even COH2 is cytotoxic. Toxic. If it was not, it would not be able to kill any bacteria, and nobody would use it. But seeing the poor results, time is past due to accept that for the purpose we apply it, COH2 is just not cytotoxic enough. That's the point. And if you still do not believe that COH2 is cytotoxic, then ask this young dentist who lost his eye view by necrosis of his cornea, getting some COH2 in his eye whilst performing an endodontic treatment. You like medical jokes? Here's another one. The same teachers who forbid the use of cytotoxic disinfectants in endodontics dogmatize the application of extremely cytotoxic hypochlorites, concentrated hypochlorite. NaOCl dissolves dead tissue. That's why we are supposed to use it. But unfortunately, NaOCl dissolves vital tissue nearly as well, as you see in the face of this poor patient who arrived at an intensive care unit of an hospital after an endodontic treatment. NaOCl and EDTA dissolve the organic fraction of the dentine, making it dry and easy to break. So we don't have to wonder about the inflation of length root fractures after endodontic treatment that we witness today. In the meantime, there are studies that prove this connection. Allergic reactions against cleaning agents increase, and NaOCl is the main component of them. Here's another joke that might even be better. Ubi pus ibi evacua. Where there is pus, get rid of it. This is the first theorem ever, that was ever framed in medicine, and it was framed by Hippocrates, who lived 2,500 years ago. And it's so strong and so valid that it's even valid today, and there's no doubt that it will be valid for the next 2,500 years. It deals with the treatment of abscesses. But a gangrene is nothing but an abscess inside the tooth. Look how nice the pus comes out of these root canals. And how do physicians treat an abscess? They incise it, clean it from pus and dead tissue, and then put a drain in it so it doesn't close by himself. This is most important for a surgeon who would close an abscess right after incising and cleaning it, would first lose his patients, and then admission. He would go to court, and he would lose the case. And how are we supposed to treat the interdental abscess? We open it, clean it incompletely, and close it immediately. Here you see the results of such a malpractice. An interappointment flare-up, not really a rare complication in endodontics. And we can be very lucky that most of those abscesses break through to the exterior, into the patient mouth. If such an abscess breaks through into the interior deep and spreads, this is a life-threatening complication that will bring the patient to an intensive care unit of an hospital. Let me tell you a nice story at this point. I don't know if you know Roots. I don't know if it still exists, but 15 years ago, I was a guest there, and there was a news group and a mailing list of the specialists in endodontics in the USA. And what I saw after a few days, there was no competition on healing apical osteosis, but there was a very strong competition who was showing the nicest X-ray. And somebody showed an X-ray, and very neatly executed root canal treatment, curved root canals and side canals and everything that an endodontist dreams of. And then they started talking. Oh, how did you do that? And they said, use this instrument and this instrument and then do this. And the very last moment, or even use this. And then go on and go on. And then they all said, oh, what a nice presentation. What a wonderful shape. And that goes on and on like that. And after a while, I got into a discussion about the treatment of an intradental abscess. And one of these guys, he started to talk to me very angrily. He said, don't tell me anything about abscesses. My father was a veterinarian. And when I was a little boy, I went with him to his farms where he treated his animals. I saw more abscesses in my life than you will ever see in yours. So I asked him very friendly, and how did your daddy treat those abscesses? Well, he said he incised them, cleaned them from pus and dead tissue, and then placed a drain in them. So I asked him even more friendly, and why do you treat your patients worse than your daddy treated his animals? There was a very, very long silence in that group, and then they cut me off. As you see, endodontic science is full of inconsistencies and contradictions. So let's have a look on what we have and what we apply. We have a complex cavity system infected more or less by bacteria, which mechanically can be cleaned to only 1/3 of its volume. And we have a periapical space and a bone area that cannot be cleaned mechanically at all. And what do we apply? A highly concentrated and hypercytotoxic hypochlorite solution, which is not allowed to reach all the infected tissues without the risk of causing severe harm to our patients. And a long-term disinfectant as an appointment dressing that is only weakly or not at all effective against the bacteria which are involved in this infection. Oh, and we have something else, at least in the US. We have specialists of endodontics learning everything about root tip resection and implantology. Seeing this background, it's not surprising at all that there has been no progress in the last 70 years in the outcome of endodontic treatment. The currently taught and applied protocol is not indication specific, and an inappropriate treatment cannot be predictably successful by definition. So the fourth conclusion that we can draw is that it makes no sense at all to hold on what is taught. Actually, if we want to improve the outcome of our success rate, change is past due. We must start to treat differently, mechanically as well as chemically, and also as far as obturation is concerned. That we still don't do, although knowing so much better since many years, reminds me of a quote of Albert Einstein, who said, "Insanity is doing the same thing over and over again, but expecting different results." So how should we treat then? What is the appropriate treatment in the case of bacteria-induced endodontic disease? The apical osteitis is nothing but a mild form of osteomyelitis. The bacterial osteomyelitis, in turn, is the most feared complication in bone surgery. Why? Because it's so extremely difficult to heal. The reason is that although the bone contains a lot of blood, there is only poor circulation. Compared to other tissues, the bone has a very, very low metabolic rate. And that's why that in most cases, it's impossible to achieve a level of antibiotics in the bone to kill the bacteria. And how do surgeons treat these abscesses, these bone infections then? They provide good access to the infected area, evacuate the fused and infected bone by mechanical means, and then they bring antibiotic granules in direct contact with the bacteria and with the rest of the infected bone and give them a very, very long time to do their work. And how are we supposed to treat our bone infection? Without providing access, without mechanical activation, as fast as possible, by using NaOCl, which is not allowed to get in contact with the infected bone, and by applying in all aspects insufficient COAH2 as an interappointment dressing. So, in fact, we do not treat the bone infection at all. We leave the patient to his fate and hope for the immune system to do our work. But as we see in a much too high percentage of cases, the immune system is not able to get rid of the infection by its proper means. It's our job to do that. To give you another example, how do physicians treat the tuberculosis, which is also extremely difficult to heal because of the encapsulation of the bacteria in the granuloma? They are treated with a powerful combination of drugs that is given for a long, long period of time. And how we try to treat the bacteria-induced endodontic infection as fast as possible, in many cases only in one session, rinsing with solutions which may not penetrate all infected tissues due to severe side effects, the risk of severe side effects, and with largely insufficient COAH2 as an interappointment dressing. Seeing all these damning facts, we must finally accept, and I'm sorry to tell you that if they knew everything that a dentist knows about the anatomy, the etiology, and the pathogenic of this disease, no physician in the world would ever treat this disease the way we are taught to do it. So let's have a look what Otto Walkov published about these problems 19 years ago. He wrote, "The pathogens are underestimated in their behavior, their resistance, and their position in far too little appreciated hiding places, even in the treatment of a simple gangrenous pulp. No dressing that is applied for a few days is able to destroy them in the way we try it. Killing these microorganisms can only be achieved by weapons that are strong enough and are applied for a long period of weeks and months." So it's all said there. You see, Otto Walkov, he knew his anatomy. And in my opinion, every dentist, before starting to treat patients, he should prove that he has very well understood what Otto Walkov said here, and that he is able to repeat these three short sentences spontaneously, even in the middle of the night, if he's woken up in the middle of the night. As you see, Otto Walkov knew everything about this disease, and he also knew about the solution of the problem. We must provide good mechanical abscess to all infected tissues, and we must apply powerful and at the same time safe disinfectants. And depending on the gravity of the infection, we must give them all the time they need to do their work properly. And this means, in this difficult anatomical environment, weeks and months. I'm going to show you right now how the endodontic protocol I propose and I use very successfully differs from the so-called gold standard protocol, which is taught and applied today. And you will see that it differs a lot concerning all the three steps in the treatment procedure. First, mechanics. When you see an apical osteitis in your X-ray, you can never be sure if it's only simple infection or it's already a beginning abscess or developing granuloma or a manifest granuloma or a developing cyst. You can never be sure about that. As I want to gain access to this tissue, to this infected bone area in any case, I push an ISO 15 instrument beyond the apex into the radiolucency, like you see on the middle X-ray. When I see pus or cyst draining, I extend the foramen apicale to ISO 30. As you can see, I do exactly what a surgeon would do. I provide good mechanical access to all infected tissues. And of course, as I deal with an intradental abscess, I leave the tooth open for 1 or 2 days or the weekend so that the patients cannot get into trouble, and the exudates and the pus which may come after can get out of the tooth into the mouth of the patient, where it would go when the way into the mouth of the patient is closed in the other direction, towards the bone, of course, and you see what happens then. Not closing the tooth means applying cotton wool drained with a powerful disinfectant. In the case of gangrene, you never have to be afraid of reinfection. The germs in the patient's mouth are harmless compared to those you find in a gangrenous tooth. And on top, they are not able to pass through cotton wool, which is saturated with a powerful disinfectant. That takes at least 1 week and longer, as scientific studies show. Second, disinfection. Which approved drugs do we have? There are not many left because most of them have been examined, like CHX or all these antibiotic solutions, and they were rejected as not successful. But time has definitely come that we find one. The whole endodontic world is searching for it. Here is what I use. A sick but vital tooth needs leather mix as first dressing for 1 or 2 days or even the weekend so that the patient does not get into trouble. Not because of the antibiotic which is in there, but because of the cortisone. Acute pulpitis causes pain, and I want that my patients get rid of this pain right after my treatment. This is the best for them and also even better for my reputation. Cortisone interferes with the pain-producing agents that are released when infection spreads in the tissue, and it blocks them. And even more important, it reduces the pre- and post-treatment pain-causing swelling. Some teachers do not want us to use cortisone because they are afraid of side effects. That's another good one. The reports of severe complications caused by concentrated hypochlorite are uncountable meanwhile, and the estimated number of unknown cases is even much, much higher. And the same teachers that dogmatize its use are afraid of a little bit of cortisone. I don't have a single drop of NaOCl in my clinic, and I really don't miss it. Cortisone, hence, is a wonderful drug with no side effect at all if applied appropriately. And if the little amount of cortisone that will be resorbed out of the hollow tooth would not be released every minute by their suprarenal glands, those teachers who are so afraid of side effects would get severely sick. So why not apply it? It's much more appropriate to apply cortisone than to prescribe painkillers and antibiotics. All dentists that use my protocol, and there are lots of them in Germany in the meantime, they all report the same thing. They are most happy about the predictability because if a treatment is predictable, even in severe cases, it changes not only the view on endodontics, it changes the view on the whole dentistry. And they report that the frequency of root tip resection declines to 0. And they report that they nearly never have to prescribe antibiotics or painkillers. Do you know the sealer we call Russian red in Germany? You certainly do, because many immigrants from Eastern Europe countries are treated that way. What do we see? A lousy preparation, insufficient root filling, and we find a rock-hard reddish sealer that is nearly impossible to remove. But we nearly never see an apical osteitis. Why? Formaldehyde is a very powerful disinfectant, maybe the most powerful from all, and the sealer contains it in a very high concentration. I'm surely not here to promote such a treatment. I just want to show you that you can compensate lacks in mechanics by using powerful disinfectants, but this does not work the other way around, that's for sure. In my view, all the people that are so scared about applying a little bit of poison into a hollow tooth to kill the bacteria that make us sick and lead to organ loss if we don't kill them, they should be much more concerned about all these chemicals we are fed every day by our food industry. There is no better and safer place in the human body for applying powerful disinfectants than the human body, than the hollow tooth. Well, I'm not here to promote the use of formaldehyde. His reputation is spoiled because it's said to be carcinogenic, although this may not be true, as new studies show. And one thing is certain, and applies to all drugs, and it applies, of course, also to formaldehyde. It's the dose that makes the poison. I want to introduce to you the 2 disinfectants which I apply very successfully as inter-appointment dressing during each root canal treatment. And you may have guessed it already. They were invented by Otto Walkov. By the way, besides other great things Walkov did, he has incidentally made the first X-ray of human teeth, and he is still honored today by his physician colleagues because he is the co-founder of the radium therapy of cancer. From the dental and medical point of view, Otto Walkov was definitely a genius. The first and most important is the original CHKM solution by Otto Walkov. Original. This is very important, as you will see. This is not the normal stuff that you might know, but this is important to understand that the original CHKM solution by Walkov is a very, very special substance. I really don't want to bore you with the chemicals, this chemistry, but this is what you have to know to understand. The most effective and controllable disinfectant that can be applied to humans is chlorophenol. And its less caustic form is paramonochlorophenol. His disadvantage is that it has a strong caustic effect, like concentrated hypochlorite. CHKM by Walkov is a drug combination of 3 powerful disinfectants: paramonochlorophenol, natural camphor, and menthol. There is nothing else in it, especially no alcohol. It's not the alcohol that serves as the solvent for the chlorophenol, it's the natural camphor. And this natural camphor is added until complete saturation of the paramonochlorophenol is achieved. If you ask a pharmacist, he will tell you at first sight that this is not possible because these are all 3 crystalline substances. But in a special technical procedure, you obtain a solution that is stable at room temperature for years. Due to the complete saturation of the paramonochlorophenol with camphor, it loses completely any caustic effect without losing much of its bactericidity. The poorly water-soluble menthol has an additional anesthetic and astringent effect. It is crucial that CHKM by Walkov does not contain any alcohol, because alcohol makes the solutions volatile and removes the tissue compatibility. And here's another important fact. In Walkov's original CHKM solution, these 3 disinfectants are not bound chemically to each other, but only physically. That makes a big difference because these connections are very loose and are already disrupted by addition of a little bit of an extremely small amount of water or secretion. When these connections are disrupted, you obtain an aqueous parachlorophenol solution in a concentration of not more than 1.3% in a steady state equilibrium. Steady state equilibrium means that independent of the amount of secretion you have, you will always obtain the same concentration until the CHKM solution is completely used up. It's impossible, though, to get to a more concentrated solution. Subsequently, you will never produce any necrosis because the concentration is much too low for that. Camphor and menthol deposit in extremely fine crystalline distribution through the whole endodontic cavity system. Due to this long-term depot of disinfectants, reinfection through the side canals and the tubules is reliably prevented, since the remaining tissue that could not be removed mechanically is sort of impregnated. Thus, it becomes most unattractive for bacteria that die when they use it as food. In addition, CHKM is extremely capable to crawl. Filled into a tooth in the root, a canal, it can be detected within 24 hours on the root surface. Avni et al. Marked the chlorine molecule radioactively in 1973, and they found that the camphor-bound parachlorophenol cannot penetrate the dentine very deeply. But the aqueous solution, however, which results when the physical connections are disrupted, is capable to penetrate the whole root up to the root cement. CHKM is thus able to penetrate all the little side canals and even the tubules. It also penetrates the periapical space and the bone, and hence disinfects all the tissues and surfaces which are potentially colonized by bacteria. Up to today, not a single bacteria has been found which is not killed in a very short time if it gets into contact with CHKM. Under the name CHKM, various products are available that also contain chlorophenol and camphor. Of course, you can mix a lot of cheap chlorophenol with a little of expensive camphor and add alcohol as a solvent. In any way, you get camphorated chlorophenol. That's the stuff you might all know. And if you add some menthol, you even get CHKM, but you use alcohol. But these cheap elutions have nothing in common with the original CHKM solution by Valkov. In the contrary, it was Valkov himself who rejected these kinds of solution and called them destructive. CHKM is neither protein precipitating, nor mutagenic, nor teratogenic, nor carcinogenic, and has no side effects at all. The only thing you can say against it, that it doesn't smell and taste so well. It tastes really bad. But it's the same with hypochlorite. But from the medical point of view, bad smell and taste, it's in no way an acceptable argument to deprive our patients from a drug with high therapeutic potency in the absence of any side effect. I talked about Sunday cases before. Of course, I have Sunday cases too. Here you see one, but you also see what is possible if you just try and you use powerful disinfectants. Unfortunately, the original CHKM solution by Valkov was put on a level with all the other CHKM preparations by scientists who obviously did not read the articles and books and studies from Valkov in the original language. And through this fundamental error, it got into disrepute. Mainly based on the studies of Spengberg and Büström, it almost lost his official approval in Germany. I could stop that in the very last moment. Spengberg in 1973 called it too toxic for human use, but he confirmed superior antiseptic effect at least. Büström compared it to CaOH2, and this study is a very, very special study because it's the only study ever published where CaOH2 has killed all bacteria. And since then we use it, and on y soit qui mal y pense. But when you read these publications from Spengberg and Büström in the original, you see that they did not apply the fully saturated Valkov solution, but cheap solutions with a lot of chlorophenol and little camphor and alcohol as a solvent. Thus, mixtures which had been rejected as unsuitable by Valkov himself. I hope I could convince you that the original CHKM solution by Volkov is indeed a very, very special substance. I also used COH2 for a long time as an inter-appointment dressing, but after its inefficiency could not be overviewed any longer, I've replaced it by the iodoform paste by Volkov. I saw quite a lot of cases since then, and my impression is that the bone healing is much faster now than before. Looking at the active ingredients, this is not really surprising. The iodoform paste can stay in the root canal for up to 6 months or even longer. If at this stage, as you see in this picture, you see I see an important decrease of the radiolucency. I do the definite root filling and do my prosthetics because I'm close to 100% sure that this tooth will never exacerbate again and that the rest of the radiolucency will vanish within a few years. This is an example of a tooth with a history of more than 10 years. He was resected already 2 times when he exacerbated again. Iodoform is very effective on Enterococcus faecalis, by the way. What a surprise. After every instrument, I rinse with a H2O2 solution in a 3% concentration. It's of course not so powerful like NaOCl, but as I do long-time disinfection with powerful disinfectants in any case, it has not to be. The big advantage is that it can get into contact with all infected tissues and also with the bone. And when you press it, you must really press it above the apex. It causes pain too, but you can tell the patient, "Oh, I'm very sorry, this pain will cease within a minute," and you don't have to call the emergency. Obturation. We cannot sterilize infected teeth and the adjoining tissues. We can only disinfect them. As a consequence, we can only achieve very, very low germ numbers, but not sterility. There will always be a certain amount of germs that will survive our disinfection protocol. For these survivors, we must make life and especially reproduction as difficult as possible, as hard as possible. This implicates that the use of a sealer which contains a powerful and very long time effective disinfectant without any side effects. Obturation with neutral sealers such as cement or gutta percha became known in Europe at the beginning of the 20th century as the American way and was rejected by the Europeans as not working. So you see, in America, nothing happened at all. They're still using the American way since 100 years. But in Europe, we made a big step backward because we already knew better 100 years ago, but we are using the American way right now. I use Endometazona N since 30 years very successfully. N stands for new and means that the formaldehyde that used to be in there before was replaced by iodide of thymol. And iodide of thymol is very effective on Enterococcus faecalis. What a surprise. When you take good care of mechanical access to all infected tissues, you cannot always, by over-instrumentation, you cannot always avoid that the sealer is overfilled sometimes. And as I noticed that you don't like my medical jokes so much, I promise you that this is the last one I tell you. Many studies seem to prove at first sight that overfilling leads to treatment failure. But nobody is asking himself why it does not in the other half of the cases. This is very easy to explain. Overfilling of a neutral sealer into a bone which is infected by bacteria is everything but helpful, because you produce more irritation. But this is not at all. This is a very different situation when there's no more bacterial infection in the bone. Non-infected bone is very nice to substances from all. It even tolerates implants. Just if you cannot follow what I'm trying to say, just insert an implant into an infected bone, bacterial-infected bone, and 2 or 3 days later, you will see what I'm talking about. Endometason N is reliably reabsorbed outside the cavitine system, and as it contains a little bit of cortisone, you will never see pain-induced overfilling when disinfection was complete. So the final conclusion we come to is that the endodontic disease is not a mystery, but it's only a simple bacterial infection taking place in a difficult anatomical surrounding. It's the only problem. If treated appropriately, it heals percentage-wise, similar to other bacterial infections, and that means close to 100%, even in severe cases. I hope you understand by now that it's no wonder that there has been no progress in endodontic treatment outcome in the last 70 years, as David Victor pointed out in 2002. It's so obvious. As our ancestors, they were restricted mechanically, they use powerful disinfectants over a long period of time. Today, we have all the mechanical means they were dreaming of, but we rely far too much on them, and we have forgotten that more than 50% of the areas potentially colonized by bacteria cannot be treated mechanically at all. Here you see an interesting case, by the way, therapeutic via falsa. Our ancestors, they did that very often, especially in curved canals, because their instrument was so rigid. And here there was no way to get into this apical osteitis by following the main channel that was completely obliterated. There was a retreatment case. So I made a therapeutic via falsa, and as you see, what worked 100 years ago still is working today. So the solution of the endodontic dilemma is very easy. We must simply do both: meticulous mechanical preparation and a long-time disinfection with powerful drugs with no side effects. The bad thing about bacteria is that some of them make us sick and lead to organ loss if we don't kill them. The good thing is that if all the bacteria are killed, there is no more bacterial infection. No more beasts, no more disease. It's so simple as that. And it's our job to kill them before we fill the root canals, definitely. To finish, I'm going to show you some of my own cases, and to show you that if you have a predictable endodontic, reliable endodontic protocol that is reliable, near close to 100%, it does not change only the view on endodontics. It has so big consequences in all other meanings. So here you see on the left side, you see the X-ray of a 45-year-old woman. She was supposed to lose all her teeth in the upper jaw and some in the lower jaw. And because of very severe endodontic, periodontic, and aesthetic problems, and if you look close at this picture, you see that it's a very poor case. On the right side, you see the to see the same woman after endodontic treatment and insertion and 2 implants were inserted. Not 13, but only 4.5 teeth were extracted, and only 2 and not 10 implants were inserted. This picture shows the technical procedure. Single crowns were produced, put back into the mouth, fixed together, taken out, and soldered secondarily. Here you see the clinical picture 2 or 3 years after the treatment. To getting to such an aesthetic result in such a poor case by full mouth implants is very difficult and maybe even impossible. On natural teeth, it's so easy. And I think you will agree that one must have very big confidence in the outcome of his endodontic treatment to do such a case, because losing 1 tooth here may mean that you lose the whole thing. This lady was supposed to lose all her front teeth because of hopeless periodontal and endodontic problems and aesthetic problems. 3 of the 4 teeth had to be cut on gingival level and served by angled posts and cores to get them back into the line. Here's the clinical picture from the side and here from the front. This very young lady, I think about 25 years old, was supposed to lose 2 premolars due to hopeless endodontic problems. As you can see, I had to cut into the bone to put the crown onto the root and not only onto the post. And the biological width, you may ask, just forget about it. If you work like our ancestors did, what means that the crowns end razor sharp in gold, it will establish by itself as time goes by. And as you can see on this X-ray, what else should it do? But whom am I telling this? You all know that gold is the best for every tooth and that all these modding materials are just surrogates. Here's the clinical situation. Dear esteemed colleagues, there are so many emperors with new clothes in modern dentistry, and many of them you find among the so-called specialists and unfortunately also among our teachers. They make a big hype, a big wave, but if you take a closer look, as we did today, you see that in fact, in reality, they are quite naked. If I had more time, I could go on and show you more and more examples in all parts of dentistry, for example, in TMG, periodontology, or prosthetics, where the advised progress, big progress in dentistry is not existent, and worse, regression took place, as we saw today. I can show you endless samples where our patients have been treated by so-called modern dentistry and yet, in the end, are much worse off than ever and poorer in any case. Among animals, you find a lot of specialists too. This one, hope it works, for example, is specialized in fast running. But as I show you today, a simple general dentist using the right... simple general dentist using the appropriate protocols can run much faster. Sorry for that. My time is up now, and even if you don't agree with what I said today, please leave your eyes open and keep your common sense. Always don't believe everything dental emperors tell you, and always expect them to be naked. If you do so, my little essay did what I hoped to achieve. Normally, my lectures finish at this point, but as I'm retired since 3 years, and this is probably my last lecture ever, I will tell you a secret. I do that now for 25 years, and I published everywhere they let me publish, and I gave speeches, I made lectures, I was in all existing mailing lists and showed my protocol and discussed with dentists. But of course, I reached a lot of dentists. But if you really want to change, and I preserved by this way much more teeth than I would ever have been able to preserve with my own hands. But if you really want to change things, you have to change the instruction of opinion. So you have to change the mind of the teachers, because if you don't achieve that, then nothing will change. But every year, thousands of dentists leave dental school and learned the wrong treatment protocols. So that was not successful at all. In the contrary, and looking back in these 25 years, I worked on it at least the same amount of hours than I worked for money in my clinic. And you may wonder why I'm still smiling and did not get depressive. So the secret why I'm still smiling is I'm about to expect to reach the 3rd level. Yeah, not in meditation, unfortunately. I'm not really a Buddhist. This is only a nice picture taking in Thailand, where I live now, that shows my state of mind. No, I mean the 3rd level in progress in science. Progress in science is very slow, and changing the instruction opinion is very hard to achieve, because all the people, you have to put in question what they are teaching, and nobody likes that. So, but progress happens, and it happens in 3 stages. So at the first stage, the teachers who you attack by questioning their protocols, they tell you, what the hell of the shit are you trying to tell us? That's a hard time. And there was about 10 years, and they told me I was a charlatan. I would poison my patients. I would lead my colleagues into the desert and things like that. It was a very hard time, but I kept on working. And about the 10 years, I reached the 2nd level. And on the 2nd level, they tell you, nothing what you are telling us is scientifically proved. So I went on working, and I looked through all the old and new endodontic literature. And as I show you today, it took me another 15 years, but now everything is scientifically proved. So I'm ready to reach the 3rd level. And I hope that I will live long enough to hear what they're telling you on the 3rd level, because there they tell you, we've been telling this since so many years, Thank you very much.